Good morning, everybody. Welcome to our channel, Denteasy. Let's make dentistry easy with the Denteasy. So today we are going to discuss about the basic concepts of occlusion. Our main motto is to study what is malocclusion. To know about malocclusion, there is a very common saying: if you know normal, then you can know about something which is not normal or abnormal. So basically, to know about malocclusion, we need to know the concepts and the basis of occlusion. So basically, if you know what occlusion is, you can easily identify what malocclusion is. In simple terminology, if I discuss what occlusion is, so basically occlusion has two basic aspects. One is called as static and another one is dynamic. The static means something at rest, or you can say something which is fixed is called as static occlusion. It means there is no movement that has been taking place is called as static occlusion. There are various components which are associated with the static aspect of occlusion, which may include: number one is the form. What do you understand by the form? Form means the shape or structure of teeth and the associated surroundings. So ऐसा तो है नहीं कि आज दांत की शेप अलग है, कल उसकी शेप चेंज हो रही है और it keeps on changing और उसमें स्ट्रक्चरल चेंजेस आते रहते हैं. नो, माइक्रोस्कोपिक लेवल पे हो सकता है. फॉर एग्जांपल एब्रेजन हो गया, कुछ और हो गया, लेकिन उसकी बेसिक जो शेप है कैनाइन की, प्री मोलर्स की, मोलर्स की या इंसाइजर्स की, वो सेम रहती है. So basically it comes under the static aspect. Number two, if we may discuss, is alignment. Once the teeth erupt into the oral cavity, they are aligned in a particular set pattern. For example, there are incisors, then there is canine, followed by there are premolars, and lastly the molars. So there is a one particular set pattern in which the teeth are aligned into the oral cavity. So that also comes under the static aspect of occlusion. It means अब ऐसा तो है नहीं आज शेप कुछ और है, कल शेप कुछ और होगी. Similar to that, आज alignment कुछ और है, कल alignment कुछ और होगी. Along with alignment, there is another third aspect which is called as articulation. Articulation here in sense means relationship of upper teeth with respect to the opposing arch, of one arch with respect to the opposing arch. For example, there is one particular aspect how the teeth have been articulated with the opposing arch is called as the articulation. There are basically two types of relationships which we may discuss here. One is called as cusp to cusp relationship and the another one is cusp to embrasure relationship. We all have been discussing about the cusp to cusp and cusp to embrasure relationship. To brief about these two relationships, in cusp to cusp there is only one single contact between the cusp, and if we discuss about the cusp to embrasure relationship, in that one tooth may contact with the opposing two arches. This is number one, this is number two, this is number three. This is called as, this is the embrasure area between the two teeth, and the cusp of one teeth falls or occludes into the embrasure area, and it has two teeth which are involved into it. So basically, whenever the contact is between two surfaces, two teeth, it's called as cusp embrasure relationship. When the contact of one teeth is with the another teeth, one teeth with another teeth is called as cusp to cusp relationship. I hope it's clear. Here I would like to brief one another aspect also. It's not only how the teeth have been articulated with each other in the opposing arch, but also how the teeth have been articulated within themselves or within the adjacent structures. Could it be the alveolar bone? Could it be PDL fibers? Could it be the PDL fibers? So they have different relationships with each other. This is the tooth, this is the PDL fibers, and this is the alveolar bone. I hope it's clear. So this was about the static aspects of occlusion. Now let's move on to the dynamic aspects of occlusion. Dynamic itself says something which is active, which is moving, or something which is functional. So all the aspects which come under functional, or they are active, or they have been moving, they come under the dynamic part, dynamic aspects of occlusion. So basically dynamics include the stomatognathic system. Stomatognathic system as a whole, which comprises of teeth itself, the supporting structures, the PDL fibers, the neuromusculature. So that is called as dynamic. If I draw a diagram here about the teeth which is being placed into the alveolar bone, or I can say if I extend it and draw this is mandibular condyle, we can say condyle itself, this is the condyle, or which is being placed into the glenoid fossa. This is the mandible itself. So if we talk about the dynamics, in dynamics it may include what kind of relationship this condyle has with this bone, which is called as glenoid fossa. As we all know, there is interposed articular disc between the condyle and the glenoid fossa, and how the relationship is between the tooth itself along with the alveolar bone, the bone which is surrounding this area, also the PDL fibers. And so basically how the neuromusculature acts upon it, the way it is working, something which is dynamic in nature. So basically it describes about the dynamic nature, something which is functional, or it is working in a coordination and a set pattern. So all those aspects, they come under the dynamic aspects of occlusion. This is how it is associated with TMJ. So all these aspects, they come under dynamic occlusion. If we study malocclusion, the contribution of person named angle is very vast. We study everything based upon angle, and he has described everything so far. So he's a person who has tried to describe, and he has defined occlusion. So he gave us various aspects according which it can be classified. So he gave us to what we call as occlusion. What Angle has to say about occlusion is that he told about the normal relation of occlusal planes of teeth when jaws are closed. So basically, what does it mean? So it basically means that whenever the jaws are closed, there is area of maximum intercuspation between the teeth. So that is how the occlusion is formed. So to study about the occlusal planes, one must know the types of cusp. Basically, the human posterior teeth, they constitutes two types of cusp. One, those are called as centric holding cusp, and another one they are called as non-supporting cusp. If we go into the details of these two types of cusp, I'm giving you a very simple way to learn it. That if I draw the maxillary teeth and if I draw the mandibular teeth, this is the mandibular posterior teeth, this is the maxillary posterior teeth. This I'm considering to be the buccal side and this I'm considering to be the palatal side. If we go into the details of this, a very easy and quick method to learn is the palatal cusp of maxillary posterior teeth. So according to this diagram, this would be the buccal cusp and this would be the palatal cusp. Palatal cusp of maxillary teeth and the buccal or the facial cusp of mandibular teeth. So this is the buccal or the facial cusp of mandibular teeth. So according to, if I redraw this diagram, this would be the buccal side, this would be the palatal side. The palatal cusp of maxillary teeth and the facial cusp of mandibular teeth, these are called as centric holding cusp. So they occlude into the central fossa and the marginal ridges of opposing teeth. They are also called as stamp cusp. On the another side, if we talk of non-supporting cusp, which were the two types of cusp which were remaining? This is the buccal side, this is the palatal side. Never get confused amongst these two types of cusp. आज के बाद कभी कंफ्यूज नहीं होंगे. सो दो इंक्लूड हो गए, दो रह गए. द बक्कल कस्प ऑफ मैक्सिलरी एंड पैलेटल और द लिंगुअल कस्प ऑफ मैंडिबुलर. These two types of cusp, these are called as non-supporting cusp. They are also called as shearing or guiding cusp. As we chew food, they help in guiding where the food has to go. It helps in shearing the food during mastication, and they help or they contact and guide the mandible during the lateral excursion movements. So that is why they are called as guiding cusp. So I hope you will remember these things. Another important aspect to study in this lecture is occlusal plane and the curves. What is occlusal plane and curves? As we are already aware of what occlusal plane is, today we'll discuss about occlusal curves. One thing which is curve of Spee, which is very important for us to know what exactly curve of Spee is, how is it important to an orthodontist, and how is it important in malocclusion and the normal occlusion, how it is formed. If we draw the diagram, I will tell you how it is being formed. If we draw the diagram, and supposedly these are the teeth, please ignore my diagram, and here are the mandibular incisors, canine, premolars and molars, right? I know my diagram is not that very good, but still we have to manage this way only. Consider this to be the canine, and this is going to be the chin area. I'm sorry. This is going to be the chin area, right? This is how it is. So basically, if we describe about the curve of P, this is 1, 2, 3, 4, 5, 6. Similarly, 1, 2, 3, 4, 5, 6. Why I have numbered these? I have numbered these because the curve of P, which I have been talking about, it starts from the tip of the lower canine. This is the tip of the lower canine. It extends from the tips. It goes around, beginning at the lower cuspid. It follow the cusp tips of the lower bicuspids and the molar, and it forms as a arch through the condyle. It forms an arch through the condyle. अगर मैं इसको आगे ड्रॉ करती हूँ, if I draw this and make a circle out of it, so it will have the 4-inch diameter. 4-inch diameter. Since this curve, it extends anterior to posterior, so that is why it is called as anterior posterior curve of occlusal surfaces. This is the anterior surface, this is the posterior surface, because of its extension from anterior to posterior direction, so that is called as anterior posterior curve. If we talk of complete denture, in complete denture also this is called as a compensating curve. I hope you all remembers what is compensating curve. This is one of the anterior posterior compensating curve. So this is important. Number 2, another curve is curve of Wilson. Now what exactly curve of Wilson is? If we draw the diagram, these are your maxillary teeth. Your maxillary teeth, and here comes your mandibular teeth. Here comes your mandibular teeth. If we draw the diagram, ignore the diagram, try to understand the concept. What concept I'm trying to convey to you. The curve that contacts the buccal and the lingual cusp tips of mandibular buccal teeth. You getting my point? This is the curve that contacts the buccal and the lingual cusp tips of mandibular buccal teeth. So curve of Wilson, since this runs into the medial and the lateral direction, so this is called as mediolateral curve on each side of the arch. Why is it formed? It forms from the inward inclination of the lower posterior teeth. If you see in detail how the teeth have been lingually inclined into the lower arch, so from that we can say it is formed from the lingual inclination of the posterior teeth. Now the question arises, how this curve of Wilson is helpful? The curve of Wilson is helpful in 2 ways. Number one, this curve, it provides resistance to the masticatory forces. Such kind of arrangement, these are the masticatory forces which have been acting upon the tooth. So this kind of arrangement of teeth, it helps in dissipate, or it provides resistance to the masticatory forces which are being applicable to the tooth. Otherwise, we can say the forces we apply, the masticatory forces, if we bite on something real hard, it may break. So there must be some intraoral forces which balances all the masticatory forces which are being acting upon the tooth. So the curve of Wilson, it helps into the dissipation, or it provides resistance to the optimum resistance to the masticatory forces. Number 2, there is the elevation into the buccal cusp. So this is the mandibular teeth, as we all know that, and this is the buccal side, this is the lingual side. So there is always a elevation on the buccal side. This is the buccal side. The buccal side is usually elevated. There is elevation on the buccal side of the cusp. So how it is important? It is important, it helps to prevent the food going past from the occlusal table. Whatever food we eat, this is the food we eat, this remains on the occlusal table only. So this is how this forms the, as we know, this is the occlusal table where the food is being crushed and is there only. This elevation of the buccal cusp, it helps in the it prevents the food from going past the occlusal table. So this is how the curve of Wilson is important. One thing I forgot to mention about the importance of curve of Spee. At curve of Spee, it says that the long axis of the each lower tooth is aligned nearly parallel to its individual arch of closure around the condylar axis. So what basically it means is, like there is canine, there is premolars, there are molars. Whenever we go from anterior to posterior, what happens is, as we go from anterior to posterior, there is a gradual and progressive increase in the mesial tilting of teeth towards molars. So whenever we go from this to this side in the mandibular teeth, they are aligned in such a way that the mesial tilt is more in case of molars. Since the medial tilt is more, what happens is, let me show you. So when the teeth are aligned, in such a way that this is the mesial side, this is the distal side. Whenever we go from anterior to posterior, the mesial tilting of molar is more. There is a gradual increase which helps in forming the curve. That is how the curve is formed, which creates this kind of curve is called as curve of Spee. So this is how the curve of Spee is formed, and this is how the curve of Wilson is formed. I hope it's clear that how is it formed, why it is important, what is anterior posterior curve, and what about the mediolateral curve, which is called as curve of Wilson. There is another curve also, which is called as curve of Monson. Curve of Monson. The curve of Monson is obtained by extending, if we extend both the curves, if we extend here in the diagram, if we extend both the curves anterior posteriorly and mesodistally, so it will passing from to all the cusp and incisal edges, so it will form the curve of Wilson. So basically it will form the curve of Wilson. As we all know, all the curves which we have been describing they all are imaginary. So they are not already available there in the oral cavity. These are all imaginary curves. Another important thing which you should know here is centric relation and centric occlusion. You need to know, first of all, we will discuss about the centric occlusion because it is easy to remember, so you can easily make up the things that what centric occlusion is. So centric occlusion basically is, as we have discussed earlier, the cusp to cusp and cusp embrasure relationship. Centric occlusion is that position of the mandibular condyle when the teeth are in maximum intercuspation. When the teeth are in maximum intercuspation, that area, that point जब ये complete और maximum intercuspation में होंगे. The centric occlusion is also called as intercuspal position. That is why. So basically है क्या? Either it's a centric occlusion or centric relation. They both describes about the position of mandible. Position of mandible. One, in centric occlusion, when the teeth are in maximum intercuspation, maxillary and mandibular, at that time, what would be the position of mandible? So that is centric occlusion. And about centric relationship, if we describe about centric relationship, in that it's the relationship of mandible to the maxilla, but when I show you centric relation is a relation of mandible to the maxilla when the mandibular condyle are in the most retruded and most superior position in the glenoid fossa. Like in this diagram, you can see that this is not the most retruded and most superior position of the condyle. This is normally how the condyle have been placed. But in case, if I draw the diagram for you again to clarify it, this is supposedly this is the condyle and this is the glenoid fossa. And if you say, if this is the most superior position of the condyle and most retruded position of the condyle, it basically means this is the position beyond which this condyle cannot move, is called as the most retruded position of the condyle, and this is the position above which this condyle cannot move, is the most superior position of the condyle, with the articular disc which is properly interposed between it. This is the articular disc. So at that time, the relationship of the mandible with respect to the maxilla, so that describes about the centric relationship. Now for the normal relationship to be in, for the tooth and the stomatognathic system to be into the complete harmonious position, it is said that centric relation should coincide with centric occlusion, so that the balance is maintained. There is a range of 1 to 2 millimeter is acceptable. So this is how it works. So this was the basic about the centric relation and centric occlusion. Since we are discussing about the malocclusion, so there was a person called as Andrews. Andrews was a person who studied the studying models of 120 patients. From that, he derived certain aspects of ideal occlusion. He considered that there are 6 essential features which are required to achieve an optimal occlusion. To those 6 essential features, he called them as 6 keys to normal occlusion. 6 keys to normal occlusion. Since we are following him, so we call them the Andrews 6 keys. We call them Andrews 6 keys to normal occlusion. So we shall be discussing those one by one. So let's get started. So number 1 is molar interarch relationship. So basically it describes about how the molar has to be placed in between the arches, between upper and the lower arch. So basically it says number 1 point is, this is the maxillary teeth, this is your mandibular teeth. Ignore the diagram please. Okay, I'll make it again. So here is the mandibular teeth. So basically we need to discuss about the molar inter-arch relationship between the maxillary and the mandibular arch. Number 1 point is, this is your buccal side, this is your palatal side as we have discussed earlier. So here the number 1 point is the mesiobuccal cusp of upper first molar. The mesiobuccal cusp of upper first molar should occlude in the groove between the mesial and the medial buccal cusp of lower first molar. Okay, let me rectify the diagram for you, or you can rectify it this way so that it's easy for you to learn that how it has to be. Consider this to be the buccal side and another one to be the palatal side. Another one, not buccal or palatal. Consider it to be the mesial side and this one to be the distal side. So that would be easy for you to imagine and understand. So this is the maxillary side. The side which we have been describing here is the buccal side only. Buccal side, we are taking or looking at the occlusion from the buccal surface. So the mesiobuccal cusp, which should be mesiobuccal cusp of upper first molar, basically, which is tooth number 6, it should occlude, the mesiobuccal cusp of upper first molar should occlude into the groove which is between the mesial and the medial buccal cusp of lower first molar. You're getting my point? The diagram which we have been drawing here is for the buccal surface only. This is your maxillary first molar, tooth number 6. This is maxillary. This is your mandibular teeth. This is whole buccal surface of the tooth. What they are trying to say is, this is the mesiobuccal cusp. This is the groove between the mesial cusp and the medial buccal cusp. You're getting my point? So what they are trying to say is, it should fall or it should occlude here into the groove. So coming to the next, I hope this point is clear to you. I tried my level best to make it clear to you. Now coming to the another point, and the another point is here, what they're trying to say is, the another point is, this is the mandibular teeth, this is the maxillary teeth, this is buccal surface only, this is mesial, this is distal. They say the mesiolingual cusp of upper first molar, which we cannot see from another side. So this is the, basically the diagram is another way round. So it says the mesiolingual cusp of upper first molar, it should occlude into the central fossa of the lower first molar. So the photo or the diagram which we have described is from the buccal side. If we look at from the palatal or the lingual side, so the cusp adjacent to it, in the same arch on the palatal side, it should fall into the central fossa, right? And the another point which here important is that the crown of upper first molar must be angulated, so that the distal marginal ridge, the crown, it should be angulated in such a way that the distal marginal ridge occludes with the mesial marginal ridge of lower molar. So this is the distal marginal ridge, this is the mesial side, this is the distal side. Upper का distal, lower की mesial surface के साथ, drawing the diagram again for you. ignore the diagram. Let me draw it. It says upper का distal, lower के mesial marginal ridge के साथ contact में आना चाहिए. So the next point which we need to discuss here is number 2, which describes about the mesodistal crown angulation. Previously we discussed about the interarch relationship. Now here is the mesodistal crown angulation. Crown angulation में क्या होता है? This is the second key. अगर हम long axis of the crown में से, supposedly this is the crown, this is the crown, और crown की long axis में से अगर हम एक line pass कर दें, this is the occlusal surface, occlusal area की तरफ, और this I have made incisor, तो आप कह सकते हैं incisal surface. This is the gingival surface of the tooth. If a line passes along the long axis of the crown, this is the long axis of the crown, अगर उसमें से एक line pass कर दें throughout the most prominent part in the center of the labial or the buccal surface, so gingival part of long axis of crown must be distal to the occlusal part of the crown. जैसे this is the occlusal part, this is the gingival part. जो gingival part है, it should be on the distal surface. So this is about the second key. If we describe about the third key, that describes about the labiolingual crown inclination. The previous we described about angulation, and this is the labiolingual crown inclination. If you understood about the mesodistal crown angulation, this is very easy for you to understand about the labiolingual inclination. So this is either positive or negative. What basically it means is, as we have described earlier, that we need to know the gingival area, right? Gingival margin. Similarly, in this case, if we describe about the inclination, in this case also, it's a very simple saying that if the gingival area of the crown is more lingually placed, if it's more lingually placed, then it is called as positive crown inclination. If it is more, if it is another way around, if the gingival area of the crown is more labially or buccally placed, then it is called as the negative crown inclination. So it was about the positive and the negative labiolingual crown inclination. So the next Andrew's key of occlusion is absence of rotation. So it is said that normal occlusion is characterized by the absence of any rotation, that the teeth, it should not be rotated on its axis, either on the mesial side or on the distal side, or it should not be placed on the buccal or the palatal side. So rotated posterior teeth occupy more space into the dental arches as compared to the rotated incisors because of the size and the form of the tooth. Another very easy to learn and grasp is next key to occlusion is tight contacts. It is said that when the teeth, when they are present in occlusion, there should be tight contacts. There should be adequate spillways or the embrasures between the teeth. So the contacts between the adjacent teeth should be tight enough, right? So this was about the fifth. And last but not the least, the last is about the curve of Spee. We have already discussed a lot about the curve of Spee. It is said that the normal occlusal plane, it should be flat. The curve of Spee should be flat and it should not exceed more than 1.5 millimeter. So this was all about the Andrew's 6 keys to normal occlusion. I hope it's clear to you. Any doubts, you can post your comments in the comment section. Thank you.